life, and I want to thank you for having me here. So, like you see in this first slide of mine, I am an additional professor at the very premier Liver and Biliary Institute in Delhi, and we do get a lot of cases pertaining to the hepatobiliary system as well as the abdomen at our institute. We also run fellowship programs in the post MD courses in radiology, both in intervention as well as diagnostic. And I hope that the cases that I'm showing to you, if you find them a little difficult for you to understand, maybe you will just enjoy seeing them and you will take back at least some points for you to diagnose these cases over your run for your exams as well as your long career that waits for you. So let's move on. I have a whole collection of cases for you today, and I'll try to show you as many as possible and explain them to you. So the format is going to be like this. I have the first slide like this is my case one. There will be a few images from different modalities, and I will be putting a question to you on that. So have a good look at the images. I will give you some hints while I'm showing you the first slide, and the next slide will be about the answers and the explanations to these slides that I will put on. You're welcome to write down whatever you want to jot down as notes and then go over these in detail. They're all given in your textbooks as well as your online teaching material. So let's move on with the cases. This is my case one. So what do we have here? We have two axial images of the liver and there is a lesion which is glaring at us. So what is your diagnosis if you get this as a case? So you can get this as a small case, as a short case, or as a spotter in your exam. What do you think this is? So have a good look at this. I have three images put together, which of course are post contrast, and there are two images which are non-contrast. So we'll move on to the solution of this and I'll explain all the images to you. Now, this is nothing but a nodule in nodule appearance of a hepatocellular carcinoma, which has arisen within a dysplastic nodule. So this liver is not a normal liver. This is a T1 weighted sequence on a plain MR, and this is a diffusion weighted sequence along with a T2 weighted sequence. Now we have this rounded lesion here. It's a larger nodule. It is different from the other nodules. There are many T1 weighted siderotic or T1 hyperintense nodules. This one is also a T1 hyperintense nodule. So there are two types of T1 hyperintense nodules. They're either siderotic or they can be dysplastic. Now, why this nodule is different is because there is another small nodule within a larger nodule. And when this happens, you have to look at this inner nodule very carefully because this is part of the process of hepatocarcinogenesis, which de novo with the nodules already existing in a cirrhotic liver. So when you have a lesion like this, you always look at a T1 weighted sequence and then you look at the diffusion or T2 weighted sequences. On the T2 weighted scan, we know that all tumors are usually hyperintense. And so here is a nodule which is hyperintense on T2 within a darker nodule. Why is it dark? Because it also has some iron content within it. And usually dysplastic nodules are not bright. So this bigger nodule is probably a dysplastic nodule. On diffusion weighted images, only the inner nodule shows some sort of restriction. What happens when we give contrast? So these are the sequential images on a dynamic study of the liver. So when we give contrast, this is the arterial phase. This is the portal venous phase where you have the portal vein maximum enhancement. And this is the equilibrium phase where the rest of the liver is also well enhanced. So this nodule inside the bigger nodule only is the one which takes arterial enhancement. And we all know that arterial enhancing nodules are hepatocellular carcinoma if they show washout on subsequent phases. So look at this equilibrium phase image. On the portal venous phase, there is mild enhancement of the neighboring larger nodule, which harbors a smaller nodule. And on equilibrium phase, this nodule shows complete take-up of contrast. It's almost iso-intense to rest of the liver. And there is a smaller nodule inside, which shows a beautiful capsule on the periphery of this area, and the inner part has washed out. So we know that this is a small hepatocellular carcinoma which has originated within a larger nodule. So this is also a very good short case for you in the exam, and you have to be very, very careful when you get an appearance like this. We move to case number 2. What is the name of this disease and what are the additional findings that you see on this? So again, we have two MR images. One, I know you all know that this is a MRCP image. This is a coronal MRCP image, and this is a coronal section of the abdomen. So you have a very glaring finding, and then the other one that I want you to know. Let's move on to the solution. So we know that these are glaringly, this is a picture spotter, that you have two multiple kidneys enlarged with multiple cysts within both the kidneys. There are multiple cortical cysts. These cysts have varied signal intensity on a T2 weighted image, or actually a Fiesta image, which is a mix of the two T1 and T2 weighted images. And here you have various cysts with varying levels of fluid or debris or hemorrhage within them and show altered appearances. The normal parenchyma, the signal intensity is completely lost. Now, this is a glaring finding, but what are we trying to show you on the MRCP image here? On the MRCP, the extrahepatic common duct is normal. The pancreatic duct looks normal too, but we see these multiple tiny small cystic lesions inside the liver. And we also have these large ducts which also appear to be saccularly dilated. So this is a Caroli's disease or a type 5 CDC, and you have the autosomal dominant polycystic kidney disease. What you need to understand is the difference between Caroli's disease and Caroli syndrome, where there is only segmental lobar involvement of bile ducts, and you also have underlying hepatic fibrosis. Whereas in this liver, for now, there is no hepatic fibrosis, and that is also seen only on biopsy. What you typically see on ultrasound are these small cystic areas, which are nothing but these ectatic ducts, because this is a ductal plate malformation. And you have these large dilated spaces that you see on the ultrasound and the central dot sign. What is a central dot made of? That's nothing but the portal vein small duct branches, which are seen within this ectatic ductal plate areas within the liver. So the location of these cysts can be diffuse, they could be lobar, or they could be just involving a certain segment of the liver. They can vary in size from few millimeters to large saccular spaces or large spaces which are measured in centimeters. So this is a typical CT. We had had an MRCP earlier. This is another child where we have a CT. This is a contrast CT, arterial the venous faces, and you see these large dilated ducts and these small cystic spaces, which are nothing but ectatic ducts, and they are communicating with the biliary channels. So this is a Caroli's disease, and there is an association that we should always look for, which is the autosomal dominant polycystic kidney disease. Let's move on to case number 3. Again, an MR, and I do have a few MRs this time because I know that MRs is what the residents would usually find difficult. So hopefully you'll be able to make some sense out of all these images. So I have 4 MR images in front of you. And you know that looking at this image, you have a special sequence here, whereas 2 other images. Now have a good look at these, and then we can discuss what's happening in them in the next slide. So you've had a good look. Okay, there are four images. So what is this? This is a hemochromatosis where you have pancreas, liver, and spleen involvement. I will just tell you all the etiologies and how the hemochromatosis happens. What you need to understand here is this is a T2 weighted sequence. This is again a fat saturated T2 weighted image. This is a T1 weighted image, which is an in phase, and this is the opposed phase, which constitutes the chemical shift imaging for this sequence. Now, what happens usually in an in and post phase, and why do we take a chemical shift imaging? We take it to see whether there is fat in the liver. We all know that. But what happens when instead of fat, you have a heavy metal deposition in the liver, which is the exact opposite of what fat is. So the fat is going to make the liver look brighter on T2, whereas if you have metal or you have heavy metal within the liver like iron, your liver parenchyma is going to look darker. This is what is happening here. There is deposition also in the spleen. Normally, we compare the signal intensity of liver to the spleen. But if we have deposition of an abnormal substance in both liver and spleen, what do? We look at the muscles. So the muscles are the only organs or structures in the abdomen, which we can see. We can make use of the paraspinal muscles, or we can use the abdominal muscles in the wall. And here we see that there is brightness of these muscles, but spleen and liver compared to these are much darker. That's the pancreas also. And why is it important to see the pancreas? Because in hemosiderosis, only liver and spleen are involved, whereas in hemochromatosis, we have involvement of both, all three. This is liver, pancreas, and the spleen. What am I trying to show you in the chemical shift imaging? Usually, there is a signal suppression on the opposed phase for fat, whereas in metals, the opposite or the reverse happens. That means the T1 weighted sequence will look brighter than the T2 weighted sequence. Look at the pancreas also. Here is the opposed phase. This will look brighter on the opposed phase as compared to what it looks on the routine T1 phase. So the opposed phase makes it look brighter instead of darker. So when you see that happening, you know that you're dealing with heavy metal deposition. Now let's look at the types. There is a primary type, which is recessive autosomal genetic disorder, and the secondary type. This is what we usually see in our clinical practice when there is increased absorption of iron, for example, in cirrhotic patients that we just saw, in myelodysplastic syndromes, in anemias related to thalassemia, for example, and if there is an exogenous, which means that there is an outside increase by ingestion. That means you're taking more of oral or parenteral iron, or multiple transfusions, or situations where you need to give multiple transfusions of blood to the patients. How do you estimate? You can estimate the amount of iron. There are many techniques now. The basic technique that is used is a dual sequence or the chemical shift imaging, with which we can also estimate fat. We can also estimate fat in T2 star sequences, or using the latest sequences on gradient images. Like I have already explained to you, there is decreased signal intensity on the in-phase images compared to the out-of-phase images. This is opposite of the effect observed in patients with steatosis. Echo time of the in-phase sequence is usually higher than that of the out-of-phase sequences. Therefore, the in-phase pulse sequence is more sensitive to iron deposits because of the increased T2 star effect. And this is what we essentially need to know. Now look at this case. What is this condition? We have the CT here, and what is the procedure that has been performed? Okay, let's move on to the solution for this. Now, this is a classical Budd-Chiari syndrome with chronic liver disease, which is happening in this patient, and the treatment is TIPS, which is transhepatic transjugular intrahepatic portosystemic shunt. Now, what does a nutmeg liver mean? So this is a picture of a nutmeg. Nutmeg is nothing but a little nut. When you cut it open, the cross section of a nutmeg shows that there is this striated appearance where you have peripheral striations and the central part looks to be brighter. So the similar thing happens in the liver. Look at this striated appearance just like a nutmeg, which is radiating towards the sides. And in the middle, you have a more spared parenchyma, and that's the caudate lobe here, which stands out from the rest of the liver because it is not hypoperfused or hypoattenuating. Instead, it is brighter. And why is that? Because here the IVC is thrombosed, the caudate lobe surrounding it has its own supply, and so it still is perfused, whereas rest of the liver, because the IVC is thrombosed, all the hepatic veins are not are thrombosed too, and so there is peripheral congestion of the liver with hypoattenuation due to the congestion or the perfusion abnormality. So hypoperfused liver, thrombus, and normal caudate perfusion constitute the triad of Budd-Chiari syndrome, which is acute Budd-Chiari and the classical nutmeg liver. Now, what is the treatment for this? In acute cases, a tip stent placement, like I said, a transjugular. So you go through the transjugular route. That's why the catheter is coming from the top. And this catheter is used to place a stent. Look at this meshed stent. The stent is put in and it is introduced into the portal venous system, which helps connect the thrombosystem with a high pressure flow in the portal vein and hence is used to opacify the intrahepatic venous system and reperfuse the liver to prevent damage. Majority of cases of Budd-Chiari result from thrombosis within the hepatic veins, whereas 1/4 arise from external compression that may result in obstruction. So any external causes like tumors or other reasons with which the liver expands can sometimes compress the IVC or the hepatic veins and lead to a secondary form of a Budd-Chiari or a HVOT or a hepatic venous outflow tract obstruction. 1/3 of cases almost are idiopathic, and that's what you will see in your real clinical practice. And the flip-flop appearance is nothing but just the name that I showed you for nutmeg liver. A tip stent, like I said, is a bridging therapy if patient is going in for liver failure and needs a liver transplant to buy time or before a surgical portosystemic shunting is done. TIPS is a procedure used for preventing further damage or to waitlist a patient for these. Whereas it is also a treatment for patients who are not amenable to transplant and can never get a transplant. This is a good therapy for them. Next case, you have a 2-year-old child with obstructive jaundice. What is the diagnosis and what is the sign that you see in these images? So now again, I have 4 ultrasound B mode images and I have 2 Doppler images for you. Now, yes, I have a candidate writing what is the appearance. Very good. Very good. So yeah, so this candidate already has the answer to this. This is excellent. This is nothing but biliary atresia. This is a triangular cord sign. This is a ghost gallbladder, and that's the other features associated with it. So what happens in biliary atresia? The clinical history itself is pointing to your diagnosis. This is a 2-year-old child. You know you're looking at a congenital disorder. The liver doesn't look normal for a 2-year-old child. There is irregularity. The echogenicity is lost. Look at the porta here. You do not see, actually, you do not see a portal vein or the portal structures that you would normally see in an ultrasound. And there is no gallbladder. Instead, we are marking 2 small points with a small echogenic area within it. This is a ghost gallbladder because there is no bile secretion. There is no filling up of the lumen of the gallbladder. Hence, you're not seeing a gallbladder. All you see is a small little slit-like structure which appears hypoechoic. What is a triangular cord sign? It is formed by the atretic bile duct. So biliary atresia could be at different levels. It could be extrahepatic, it could be intrahepatic, or involve both. Now, that depends. That extent needs to be seen on MRCP. It cannot be really delineated on an ultrasound, but we can definitely look for the sign and say that, okay, we don't have a common duct formation here, or I do not see a common hepatic duct on this scan. So on this B mode ultrasound, you're able to pick up these findings and say that, okay, you're looking towards biliary atresia. Now let's look at the Doppler images. What does this Doppler show us? So the Doppler shows that there is no portal vein. So what is this flow? You're getting some sort of a venous flow. It's monophasic like flow. There is no phase city. There is hardly any velocity of the flow. So you don't have a proper portal vein formation, like I said. And all you see here is a little bit of flow. And this is the atretic portal vein, which is characteristic in biliary atresia. Because the portal vein is atretic, the hepatic artery becomes hyperplastic and you see a dilated hepatic artery with increase in its velocity, which means it has gone up to 42. Usually it will not be so high. It will remain up to 25 to 30. And when the portal vein function has to be taken over by the artery to infuse the liver or perfuse the liver, that's when the artery becomes hyperplastic. Okay, next case. This is more like an emergency room case that you will see as residents over your night duties or night calls. And we must be able to identify the findings. So we have a 62-year-old male who has a known case of cirrhosis. He's a known cirrhotic. He presents to the emergency room with features of sepsis. He has infection, fever, and there appears to be multi-organ failure. The kidneys are not functioning. The KFT is abnormal, and he's also in shock. Patient is sent to you for CT. You do a CT here, and what do you see? So you have multiple findings, and if you've had a look at them, I would welcome somebody to put this in the chat too. We had a very enthusiastic student in last slide. Anyway, so I'll move on to the solution to this. So what was the striking feature of this scan? This is again a short case that can be given to you. There is gas in the portosplenic axis. We keep reading about it in our books, but when you actually see it, you have to look for it in a finding like this. There is air in this SMV here. There is diffuse thrombosis of the portal vein as well as the SMV. And because of this, we are getting, look at the air in the axial section. This occlusive thrombus is partially occlusive. And because of this, this patient has gone into mesenteric partial ischemia as well as subacute bacterial peritonitis. How do we know that? There is ascites, of course, could be because of cirrhosis, but there is enhancing peritoneal thickening and lining of the peritoneum is showing abnormal enhancement. Apart from that, the small bowel loops are dilated. Look at the fluid-filled loops. And you have the beautiful string of pearls sign or the pneumatosis intestinalis that you see on the axial section. You must look for these signs. Having air on the portal vein, is a indicator of bad prognosis, and this patient we could not save, and this patient eventually succumbed to the disease. Another ultrasound for you. What is happening on this slide and what are the Doppler findings associated with it? Have a look. There is some sort of Doppler color filling here, and these are the spectral traces that we are trying to show you. Of course, they will be associated with some velocities that will be given to you. So this can also be given to you in the exam. What you need to understand here is that you know that you could see this little structure, this long linear structure with echoes here. So this appears to be a stent. We've already discussed an angiographic image of a tip stent. I wanted to show you an ultrasound image, which is more often seen because you will get a patient who's on follow-up, has had a tip stent put in, and you put in Doppler and see, okay, there is a metallic stent here. We know a stent connects the portal vein to the IVC through the hepatic vein. Usually it's the right or the middle hepatic vein. And we do see color filling up to here. So you're seeing color filling in the portal vein up to this segment. This is where the stent has started. Look at the aliasing or the turbulence at the site of the entry of the stent from the portal vein lumen up to the IVC lumen. This part is not opacifying with color. You think this is a thrombostent. So what do? You look at the spectral tracing. You do get trace in the portal vein, but you get a reversal of flow in the stent, and you do not get an adequate flow. This is a tip stent with blockage in it. It is very important to identify these patients because over long term, if not restented or treating, their liver will get damaged and they will have to undergo a transplant, which is the only way to save their liver. So a normal tip's velocity is higher than what you would expect in the portal vein itself. It'll be anywhere between 90 to 190. When do you say that there is turbulent flow? Only if it is more than 190, or there is a impending stenosis or thrombosis if it is less than 90. The normal portal vein before entering the stent is 30. Within the lumen of the stent, it will be this much. Do not think that this high volumes or velocities is because the portal vein is, the stent is not working or there is something wrong going on with the flow dynamics. This is how the dynamics is because there is change of pressure between the systemic and the portal circulation. The waveform is usually phasic, and portal vein branches will normally show you reversal of their flow into the shunt. So this is the main portal vein like we saw, but because our stent was thrombosed, we did not get a full color filling, although there was reversal of flow seen in the color Doppler and the pulse Doppler. So it's very important to identify that. Now, next case, I have another procedure that has been performed and the corresponding CT images with it. I can give you a few seconds just to look at it, and then we'll move on to the solution of this case. All right. So we have these three angio images. What did you see? You saw a catheter in the midline, and then you see this thin microcatheter extending to one of the vessels. Now, when we have a midline catheter, we can assume that this is probably in the aorta also because it's pointing towards the ventral aspect. So you have to also look at how many arteries are moving towards the ventral aspect. And because it's going to the left of the abdomen, it should either be the splenic artery because it's at the level of D12. You see the last rib here, so it's at the level of D12. And what artery do you have? The celiac, which bifurcates and goes into the hepatic, common hepatic, and the splenic. So this is moving towards the left side of the abdomen, and you can coordinate that with your CT images because you know that there is something wrong with the spleen. So the splenic artery here has been embolized. There is a embolization procedure which has been performed by choice. And here you see this artery which was filling in earlier has now it was thick and dilated, and now in the rerun they have thrombosed this part, they have embolized this part, and you see that the rest of the artery branches are not seen. What do you see on CT? This is an infarcted liver which happens after embolization because we are blocking blood supply to the spleen, and we want to reduce the splenic volume. So we want to reduce the functioning splenic volume to a smaller part than what it was. So we had a huge spleen on our hand. This patient had was a pre-transplant patient. Patient had to be taken up for a liver transplant, but he had hypersplenism. So no, all large spleens are not hypersplenic. Some large spleens can be hypersplenic. When do we see that? When we see splenomegaly along with pancytopenia and there is bone marrow dysfunction because of the enlarged spleen size. So what do you want to do before surgery? You want to reduce the size of the spleen. You want to reduce the pancytopenia caused by a large spleen. There is increased destruction. It is overdoing its function that it should normally do. And we want to hence divert the blood flow to the rest of the circulation and decrease the blood flow to the spleen. So these are nothing but iatrogenic or purposely created infarct so that we have less volume of the spleen to supply. So this is an important procedure that you need to know, and you can get spots of this too. Okay, so in this case, I wouldn't really expect all the residents to know this sort of tumor, but this is an appearance that you must keep in mind, and it can come to you as a short case just for the differentials that you maybe wanted to know. So what you see here, have a good look, and then we move on to the solution. So this was a case of hepatic angiosarcoma. This is a cirrhotic liver. That's the first thing we need to see when you see any tumor. Is the liver cirrhotic or is the liver non-cirrhotic? As soon as you know that this is a cirrhotic liver, this is not a normal liver. This is irregular. It is enlarged. It is not a shrunken cirrhotic liver, but yes, it is a left lobe. The right lobe looks smaller. There is widening of the interlobar and periportal spaces. And of course, it is a very heterogeneous enhancing liver. But what is important is to see that on the arterial phase, you see these large masses which have no structure to the enhancement pattern. So this is sometimes it's capsular, it is filling inside also. And then you have this capsule formation here, but you have washout here. There's no washout here. In the later phases, you see some areas of washout. So all in all, the pattern of this liver is a bizarre pattern. It's enhancing, it shows arterial enhancement, it shows areas of washout. It does look like hemangioma at some areas because you feel that it is coalescing together, but the overall appearance of the liver is not that it is a benign looking lesion. Also, always remember, think many times before you label any lesion as a hemangioma in a cirrhotic liver, because more often such lesions will be tumors rather than hemangiomas, and those are the mimics that you need to rule out. So what are the teaching points? Whenever you see an atypical vascular lesion, especially in elderly patients in a cirrhotic underlying liver, and also if the AFP is normal, you must think of sarcomatous lesions like angiosarcomas. They're hypervascular and bizarre. They can be solitary or they can be multiple, for example, in this case, and they may sometimes show progressive centripetal filling, but they should not be confused with hemangiomas. And this pattern could be a lead pointer to hepatic angiosarcoma. I have a surprise MR brain for you in the abdomen section. And why is that? Because there is an association. So these are the findings of the brain in a patient with chronic liver disease. What do we see here? I can show you in the solutions now. So there is an entity known as hepatic Parkinsonism. It shows changes in internal capsule, globus pallida, and extrapyramidal tracts. Why? Because there's accumulation of ammonia, manganese, and lactate as a patient develops hepatic encephalopathy. As the levels of ammonia rise in the blood, when the liver cannot synthesize or cannot filter ammonia out of your blood, that's what happens in a patient with CLD. The brain starts showing changes too. So it's also known as there's a lot of work on gut brain axis or the gut neural axis, and this is the result of that. You start getting T1 hyperintensities in the globus pallidi. This extends to the extrapyramidal system, and it shows changes in the midbrain as well as the brainstem. So whenever we see changes like this associated with CLD, we know that we are dealing with hepatic encephalopathy or hepatic Parkinsonism. Very, very interesting case. And I think every radiology resident should be aware of this now. So we see some abnormality, which is the center of this screen. And any guesses, I wouldn't know, but I can explain the findings to you in the next slide. So what do we see here? Normally, we know that the splenoportal axis is formed by the SMV and the splenic retropancreatic splenic vein. They join together, they fuse, they form this main portal vein, which drains the perfuses the liver. And this structure should usually be an IVC, which is communicating with the suprahepatic IVC. But what is happening here? No portal vein is being formed here. There is some vascular structure. This is probably another vein or some sort of a collateral, but no portal vein formation. Instead, the SMV and the splenic vein are joining together. They join here. Look at the structure here. These two structures are joining here together and they are draining into the IVC. So there is absence of the portal vein, and this is known as an Abernethy malformation. This was a 14-year-old girl, a boy who had this malformation. And there are three types. There's type 1A, B, and 2. In 1A, there is an end to side. So the IVC has the side and both ends, which means the SMV and the splenic vein independently drain into the IVC. Whereas in type 1B, you have the combination, which is what we had here. This is a type 1B. We have a combination of the splenic vein and the SMV, and it's joining into the IVC. So we have a type 1B malformation that we are showing you. And then, of course, in some cases, you can have an atretic sort of a portal vein, which is formed first, and then that drains into the IVC. So these are the three types. Just a quick word on the differences. They're usually seen in a female. Type 1 is more common in females. Type 2, there is no gender predilection. There is congenital absence of portal vein, whereas in type 2, like I said, it's partially atretic portal vein is made. It's formed. And other congenital anomalies are more often seen with type 1. Type 2 doesn't have many. This is at a younger age. For example, in our patient was 12-year-old boy. Later in life, portal vein, like I've said, I've already shown you the example, so you can read this up. So this is an end to side and a side to side. It's a very important malformation that we all must know. Now, this is a different sort of a slide. We have a B mode ultrasound. What are these? And what is the abnormality that is being shown to you here? I'll straight away move on to the answer. So this is like we can see here, this is not a normal looking liver. This is a heterogeneous liver. It is cirrhotic. And we have this abnormal hypoechoic heterogeneous mass lesion in the right lobe of liver, which is also exophytic and projecting out. Now, we have performed a contrast enhanced ultrasound, and these are what the images of a contrast enhanced ultrasound. In these images, we could also have a color coding. So only thing is that this is not colored and you can have a colored image. So if you see in articles, they're all colored just because this is the software that's giving them the color. But essentially, this is what contrast looks like. It opacifies in the arterial, portal venous phase and delayed phase, just like in a CT or an MR. Because this is a hepatocellular carcinoma, we can demonstrate that this is the arterial enhancement of the lesion. This is the portal phase. Look, the capsule has started forming. The central part of the tumor has washed out, and in the delayed phase, this is part of the tumor that is washed out, and rest of the liver is taking up the contrast. What is this? Like I said, this is, you have to see the structure. This is the portal vein. This is the B mode image, which shows some heterogeneous contents within the portal vein. And this is nothing but a tumoral thrombus, which is enhancing during the arterial phase of the administration of contrast. So this is a HCC on a contrast enhanced ultrasound along with a tumor thrombus. Now, this is a spotter. This is a very simple case. This is a cirrhotic liver, and we can see some abnormal findings right here at the porta. What are these? So these are nothing but very simply seen peribiliary cysts. What are peribiliary cysts? The bile ducts which are seen accompanying, or the bile ductules which are seen accompanying the vascular structures, for example, the portal vein. They are seen as hypodense cystic lesions which are seen along the portal tracts. They're seen along on both sides of the portal tract. So if you see them with on both sides of the portal tract, but on MRCP, they are not seen to connect with the bile duct lumen, contrary to what you saw in the Caroli's disease. They're also seen as associations in polycystic pancreas and kidney disease, but they need to be differentiated from Caroli's disease. They are essentially benign, and they are not pathological. They are just an association, or they may be seen associated with other conditions. So I've changed the window setting for these two images, and there is another image. So have a good look. There are multiple findings in this, and this could come as a spotter case. Okay, so if you've had a look, let me move on to the solutions. So this is an intrahepatic lipoma. The window setting is made just to make it clear that this is a fat-containing lesion, not a fluid. In this image, I've also shown the HU, which is minus 27 average HU within this lesion. Apart from that, this patient has multiple shunts in the connecting the splenic vein to the retropancreatic splenic vein as well as the renal vein. What is happening to the kidneys? There are multiple lesions in the kidneys as well. This is a left kidney and this is a right kidney. Look at these lesions here and areas of enhancement as well as fatty attenuation and soft tissue within the kidney. So there are multiple renal angiomyolipomas along with an intrahepatic lipoma as well as a portosystemic shunt formation in the splenic and renal vein. Intrahepatic lipomas are benign conditions. There is no pathology. They're extremely rare mesenchymal benign tumors, and they can range to large sizes of up to 6 centimeters. Whenever you see them, you must think of associations such as tuberous sclerosis and always look for multiple angiomyolipomas or lipomas in other organs like the kidney and the pancreas. Okay, to the next case. So we have a 7-month-old baby with intermittent cholestasis. What is your diagnosis? This is a spotter. And I'm sure many of you have already got this. So these are coronal reconstructions of the CT image, which shows you the extent of this lesion. And you have an axial image, which shows you the intrahepatic dilatation. So this image is a classical spotter image. And by now, I know you have already got it. No, this is not a choledochus seal. This is what you have to see. You have to be very careful with your Tudani's classification. There are multiple types. I will just show you the chart. And you can refer to this chart as well as have a look at your books. So you see, this is not a choledochus seal. This why? Because the entire common duct, which is the entire duct extending from intra to the extrahepatic course right up to the ampulla. You see, this is an elongated structure. So the entire thing is dilated and the intrahepatic ducts are also dilated. A choledochus seal will only have a small segment which is dilated. Whereas here, everything is dilated, including the intrahepatic ducts. So you have to look at the shape of the duct. You have to look for intra and extrahepatic extension. This liver, of course, has decompensated. So you cannot miss talking about the ascites and the enlarged liver in this small baby. So this is a Tudani's classification, and this is what a choledococele is all about. It's just a periampullary region. There is a dilatation at the ampulla, whereas this is what we had. We had a 4A, which is intra and extrahepatic ductal dilatation. The shapes are also important, and you can go in detail over this. This is a Caroli's disease. So we've already seen the Caroli's, and we've seen the type 4A today amongst all the cases. This is a very simple case again, but you have to be vigilant when you're reporting such a thing and also looking at these lesions. A 53-year-old lady is presented to us with jaundice and she has come for a routine MRCP. Now, what do we see? We see on the MRCP is a dilated duct and we see some linear hypointense structure within the lower end of the duct. We don't know what this is, but any guesses? This is nothing but a worm. This is a parasite. Absolutely wonderful. He's got it. So this is a parasite. This is just a roundworm. Very common in Ascariasis. Very common in Indian situations. On ultrasound, you can pick this up in the CBD as a stripe sign or a spaghetti sign. On MRCP, which is the best non-invasive method to have a look at this, there is a hypointense structure and you can see a three-line sign in thick slab MRCP, which means that you can sometimes even visualize the gut or the intestinal lumen, which appears as a T2 hyperintense structure inside the walls of the roundworm's body. So this is a classical sign that you may be asked. All these signs are the same. Must keep an eye out for this condition. Now I have another slide pertaining to the biliary tract. So this is a patient with the same pathology. This is one patient and this is another patient. So they have a similar pathology, but one has a gallbladder and the other doesn't have one. This is post-cholecystectomy status. Any guesses for this? So I'll come straight away to the solution. So you see there is a obstructed large calculus which appears hypointense. It's like a signal void almost. This is a large calcified calculus sitting here at the confluence of the main duct, and this is in the stump of the cystic duct. So the gallbladder has been removed, but there is a stump left of the gallbladder neck. Usually that will be left out with the lap cholecystectomy and it will be present here. Now this calculus has not just obstructed it, it is causing dilatation of the intrahepatic ducts. Similarly, in a gallbladder neck, if you have a gallbladder with a neck calculus which is impinging onto the common hepatic duct and subsequently causing intrahepatic duct dilatation, you know you're dealing with a Miriz's syndrome. And what happens if this is prolonged? There can be a perforation of the gallbladder wall and there is partial contained rupture of the gallbladder here. So this patient will present with acute pain and fever as well as small perforation. MRCPs or CT is the best modality to look at this. Now moving on to the next case, I have a few images of CT. This is a contrast enhanced CT. What do you think is the diagnosis? So we know this is not a normal looking liver. And there is, of course, what you need to pick up is there is something abnormal with the spleen as well. So this patient has multiple granulomas in the liver and spleen, and this appearance is actually a pseudo-cirrhotic appearance. This is not true cirrhosis. This patient had a history of granulomatous disease, and when we saw the liver, we went back and asked him, why did we doubt that? Because there are multiple enlarged lymph nodes also seen at the porta, mesentery, and retroperitoneum. The liver looked like an infiltrative pattern and some discrete nodules were seen all over and the spleen was also involved. So you have hepatic, splenic and lymph nodal involvement. Must think of an infective process, usually tuberculosis, whereas this patient had sarcoidosis. Why? We do not see any necrosis in these nodes. This patient had cholestasis, had hepatic abnormality. It can mimic biliary cholangiopathies and usually these are not well seen lesions. They're usually infiltrative or discrete or multiple granulomas or hypodense lesions within the liver. Another patient, I know all of you know that this is a classical sign, but there is something else to this case, which is why I have brought it for you to understand. So what do we see? We have two axial images and three coronal images. We all know what this is. What is happening in these slides? Let's move on to the solution. So we all know this is a hepatic. There are multiple which are placed as a periphery. There is a hepatic small rim of calcification. This has been a long-standing lesion sitting here in the segment 4 of the left lobe of liver. But what we are seeing here is that there is some extension of this lesion into one of the bile ducts or an inferior part of the lesion, and there is some heterogeneous debris or hyperdense contents within this lumen. This is a coronal image, and we see that there is some sort of communication happening here. If you look at this reconstruction, the bile duct is extremely dilated. There appears to be a communication at this side between the inferior segment of this hydatid and the bile duct. So this is a ruptured hydatid cyst into the biliary channels, and that is why you're seeing a dilated duct. So the clue is In 18 to 20% cases, this perforation can happen. It's very often seen in Asian population, and we must always think of this. The modality of choice for this is an MRCP or an MRI. Look at this T2 weighted sequence. You have the floating membranes within the hydatid, and you can actually see this segment where there is a small area of there is a break, or there is a break in the wall, and this wall seems to be communicating with this bile duct. When you see that happening, you also see dilated bile ducts. So the clue is, if you get dilated bile ducts, you have to make sure that this is not just compression and splaying, but it could also be communication of the cyst with the ducts. And sometimes on ERCP, you can actually pull out the membranes and debris from this. Coming to the next case, this is again MR sequence. These are three separate MR sequences: T1, T2, and a fat saturated T2 sequence. And what are we seeing here? Please have a good look and move on to the solution. What is the procedure required to treat it is also what we need to know. So this is recurrent pyogenic cholangitis. This is a T1 weighted image. This is fat saturated, and this is a cirrhotic liver. What do we see? Essentially, the right posterior segment is completely atrophic. We see these linear channels, which are T1 hyperintense. So whenever we get T1 hyperintensity, we think of three things. We think of fat, we think of hemorrhage, and we think of debris. So proteinaceous contents, fat, and hemorrhage can be bright on T1, or calcification can be bright on T1. So when we see these linear channels, we know that they can be bile ducts. And why are bile ducts appearing T1 hyperintense? Because they contain a lot of debris and sludge within their lumen. When we look at the T2, we see these T2 hyperintense ducts, and some areas which were showing hyperintensity on T1 appear dark because sludge or debris will appear dark on T2. Whereas the duct which contains bile or fluid within it will be bright on T2. This is the MRCP sequence which shows fluid around it, and these are some dilated ducts. There is severe involvement of the right posterior sectoral ducts, whereas the right anterior ducts are, some of them are involved. Because of this, the entire liver has undergone atrophy and undergone damage and has become a chronically diseased liver. Non-invasive evaluation is definitely preferable, and MRCP is the modality of choice. Why? Because we do not want to introduce infection during a endoscopic cholangiopancreatography, because we don't want any infection as an ascending tract into an already damaged system. What is the treatment of choice? Hepaticojejunostomy is performed for these patients, and which is why the duct is removed. These are dilated ducts. So this is another similar patient. Here, only the left system has hepaticolithiasis. This is the MRCP sequence. This is a fat saturated T2 sequence, and this is a contrast enhanced MR. This is again a non-contrast coronal T2 image. So on the MRCP, what do we see? We see dilatation of ducts. This part of the bile duct has now been removed, and this patient has had a hepaticojejunostomy. After hepaticojejunostomy, you will see air also within these ducts. But since you're seeing a particular long segment with multiple filled calculi, see this on the T2 sequence, you will see these dark calculi within the dilated ducts. This area has been strictured. On the contrast study, we see that there is enhancement of the wall of these ducts. So there is associated cholangitis. So this patient has dilated ducts. Look at this. This patient has probably got a blocked hepaticojejunostomy here, and the hepaticojejunostomy is not working, which is why bile is not able to drain out through the hepaticojejunostomy. There is inspissated contents and stones which have formed in dilated system. And also there is cholangitis because of the persistent dilatation and sludge sitting there in the ducts. There is cholangitis, and hence the walls of the ducts are enhancing. It's a very, very important case. Recurrent pyogenic cholangitis is very commonly seen in Asian population, and we all must know this picture if we are living in this subcontinent. Okay, I think I can stop with this last case. And this is a very interesting case. So this is a 54-year-old female. She came to us with multiple episodes of vomiting and epigastric pain for almost a month. And when this patient came, she had an amylase of normal 69, and the alkaline phosphatase is much higher than what it should be. What do we see here? So this is an axial CT image. This is a stomach. We see this is part of the pylorus, and What is this? This is a lamellated large calcified stone. So we see this is a large enterolith or a calcified stone. How would it form? This is basically a, either it's an enterolith or it's a calculus. So it cannot be a calculus. So what can it be? So we trace this little tract. Yeah, so phytobezoar, our resident says, okay, that's a good guess, but there is something else you need to see. You see, there is a small tract, there is a small hypodense tract along with the pylorus. And if you track it in the coronal sections as well, it is opening into the gallbladder lumen. So this tract, this is the pylorus. It has blocked the pylorus. It is opening into the gallbladder lumen. This is not really the pylorus. This is the gallbladder lumen, which is distended and thickened where it is communicating. So this is nothing but a gastric version of a gallstone ileus. So this was a gallstone, large gallstone, which has eroded from the neck, formed a path and migrated into the pylorus and embedded there. This had happened about a month ago. This calculus was sitting there and look, the patient has gastric outlet obstruction. An endoscopy was performed and this large calculus that you see here, this was removed and this was found embedded in the pylorus. And look at this section now, you can beautifully show the path or the track of this calculus, exactly like what happens in a gallstone ileus. So this is a sort of ileus. Instead, it's happening in the stomach, so it causes gastric outlet obstruction. So this is also known as the Bourret syndrome. The gastric outlet obstruction due to an impacted gallstone in the duodenum secondary to a cholecystoduodenal fistula. We also reported this case. It's a particular form of gallstone ileus which occurs in only 3% of cases. So it's very rare. But if you see something like this, always look for signs of perforation or migration of such a calculus from somewhere else, or perforation of this calculus, or let's say even a phytobezoar outside the pylorus to another structure around it. We must look for these findings before we form our diagnosis. I think I can wind up with these cases, and I do have a lot of more cases, but I can keep it for the next session and we can take some questions because I've shown a very exhaustive list so far. And I think we can do another list some other time and can take some questions in the remaining 10 minutes.
Thank you very much, Dr. Shalini. Students, you may type your questions in chat box.
Okay, so we have a question about intrahepatic angiosarcoma by Vishal. So what would you like to know about intrahepatic angiosarcoma? Can go back to the slide. Yes, here. So we have the slide. So you see, intrahepatic angiosarcoma, you can read. I have cited this paper. We have published this case in, it's there on PubMed. You can go, you can take this citation that I'm showing you right now. And we have discussed this in detail there. A lot of differentiate. Okay, I'll take the next question. So I think for Srinivas, he can take this and you can have a look. And these are the main points that I've shown. And this is how the lesion will look like. So this is a very good learning case for us also. Okay, so I have another question about how to differentiate between dysplastic and cirrhosis. Okay, so now my point is this. You see, you have to understand. Cirrhosis is a process. It's a diffuse liver disease, right? So in a cirrhotic liver, this is a cirrhotic liver. It has different types of nodules. There are three types. There is a regenerative nodule, there is a dysplastic nodule, and there is a cancerous or a malignant nodule, right? So as long as it is benign, it is called regenerative. All nodules in the liver, this is all our cirrhotic nodules. All are cirrhotic nodules, okay? Now, what do we call cirrhotic nodule? as long as it's benign or it is borderline benign. As long as it is like that, it is a cirrhotic nodule. The minute it becomes a malignancy, it becomes starts enhancing with washout. It is not a cirrhotic nodule anymore. Then it's a tumor. So then it becomes a cancer. Before that, this liver, which shows multiple nodules of different types and sizes and different attenuation or different intensity on MR, this is a cirrhotic liver. It's involving the whole liver. Dysplastic nodule is a different type of nodule. You see, it is a bridge between a benign and a malignant nodule. So it will not behave like a benign nodule. See, this big nodule is dysplastic. It is not behaving like other nodules. You're seeing it as a discrete nodule. See, here also, it is darker than the other nodules. So all these other nodules are regenerative. This is a bit darker here and a bit brighter here. So it's standing out. It's a dysplastic nodule. It's on the border of becoming something different. It is evolving to a malignant nodule. Within this dysplastic nodule, this small part has become malignant now. Later, this whole nodule will become malignant. So it is in the process. So we can see this process on MR now with the new techniques on MR, on imaging. We can actually diagnose this. And what happens when I diagnose this for the surgeon? He will be able to remove this entire lesion depending on the criteria. If it's a smaller lesion, if it's less than 5 centimeters, he can actually resect it or give it a transplant. So you can remove this before it has turned into a full blown malignancy. So dysplastic nodule is very important for us to differentiate. Dysplastic is in general a pathology term, but we use it on imaging when we see something like this, something really classical. Otherwise, you don't have to call a nodule dysplastic. Okay. So I think that's all I would give it at this time. Otherwise, this can go on and on the discussion about dysplasia. Anything else? Last ultrasound. Okay. So this is a long topic, but what I can say to you is that you can have a look at any of the recent papers. We also have a paper we had published from our institute on contrast enhanced ultrasound. It's been published in the World Journal of Radiology. Just type in my name, Laroya, Laroyast, Shalini Thapar Laroya. And we have a paper where we have described the technique and various lesions, the various HCCs that we saw on contrast ultrasound in the liver. So there's a lot of theory to this. So contrast ultrasound, so what is usually available in India and most of Europe is, sulfur hexafluoride, which is there are these air bubbles and they are coated with sulfur hexafluoride and they are injected. It's a very simple outpatient procedure. You see a lesion on B mode ultrasound. Only if you see a lesion on B mode ultrasound would you be able to scan a patient on contrast ultrasound. So you have to be able to see it first on ultrasound. Then you inject about 1.5 to 2 ml of contrast. As your technique gets better, you are able to inject only 0.5 ml. And once you inject that, so what happens is you use a low mechanical index. So when you put contrast, the rest of your image is darkened. There is blackness around it. You don't see the rest of the liver. Now all you're seeing is a contrast being administered. It will go into the vessels and it will only enhance the tumor. Rest of the liver is not seen. So then you will keep timing it. And once you time it, you will see that this lesion is enhancing or washing out. And you will also be able to. So there is a dual panel on the ultrasound machine with the software imbibed in it. You see the contrast study and you see the B mode study on the side. So you can identify the structure from this side and then see how it is behaving on contrast. Okay. So both the things you can do. So usually we have sulfur hexafluoride. Now Sonozoid is available in Japan and other countries like Korea. It's not used in the rest of the world. That is a Kupffer cell specific contrast. So that lasts even longer. Okay, and contrast has many applications. You can read up about it. I have another question. Are there any types of rupture in hydatid cyst? Of course, there are many hydatids will rupture. So the most common is what? What are we worried about? Biliary communication, because many of these hydatid cysts, they'll be adjoining biliary structures, right? So like this hydatid, usually they will splay your bile ducts. They can rupture into a vessel, but that is very, very rare. I haven't seen any so far, and I'm sure there must be some case reports on that. But biliary communication is the commonest. Of course, they can rupture inside the peritoneal cavity or into the lung cavity. And both of these situations, can be can cause anaphylactic shock. And rupture within the bile duct is, of course, still a more closed system because it's not falling into the peritoneal cavity, but it will cause widespread cholangitis. And hence it needs to be rectified, and you need to stent it. And then, of course, once it is drained out, you will have to remove the hydatid and seal off the perforation. Something about DIPS procedure. Okay, so intrahepatic portosystemic shunt, like I said, there is a transjugular and then there is a direct. So you can go, instead of going transjugular route, you will do a direct intrahepatic portosystemic. That means you go straight away subcutaneously. Also, it is usually done in children. So DIPS procedure is most often done in children. It is used for pediatric patients, and most of the indications are the same, like I've shown you in tips, and most of them are for Butt-Chiari or HPOTO situations. Okay, so you can read about this also further. This was not in part of my slides, but yes, DIPS is just an extension of TIPS. So instead of going through the transjugular route, you go directly. More often done in pediatric patients.
Thank you very much, Dr. Shalini. You have covered almost all the questions. Thank you very much for
Thank
the
you.
presentation, and thank you very much, students, for joining us.
Thank you. It was a pleasure. Thank you so much.